Welcome everyone to our webinar, Vision, Aging, Falls, and Fall Prevention, Part 3, facilitated by the Fall Prevention Community of Practice. My name is Mariel Ang, and I am the project coordinator at the Ontario Neurotrauma Foundation. ONF supports the Fall Prevention Community of Practice and its online platform called Loop. Loop is a place where fall prevention practitioners connect. Visit us at www.fallsloop.com. Marguerite Thomas also joins us on the line. Marguerite is the liaison for the Fall Prevention Community of Practice. She will be assisting with facilitating questions in the chat box today. Before we begin, I'm going to give you a quick rundown on the Level 3 meeting system. The webinar technology consists of two parts. The audio is provided through a telephone conference line, and the visuals are provided through a web platform. The phone number for the conference line and the link to the web platform were sent to you by email after you registered for the webinar through Level 3. If you have any questions about the technology at any time during this presentation, please type them into the chat box on the left-hand side of your screen. Alternatively, you can email me at mariel.ang@onf.org, and I will work with you to resolve technical issues as soon as possible. If you have a topic-related question during the presentation, please type them into the chat box. During the Q&A, questions will be read aloud to the group. If you prefer to ask your question over the phone, we'll provide the instructions to unmute your line during the Q&A. The webinar is being recorded, and a YouTube link will be sent to all participants in about 1 week, along with the presentation slides. I would now like to introduce our presenters, Dr. Lois Calder and Dr. Tammy Labreche. Dr. Lois Calder graduated from the University of Waterloo School of Optometry in 1980. Following a 2-year teaching position at the University of Benin in Nigeria, West Africa, she returned to Canada and joined the team at what was then a new nonprofit clinical referral facility, now called the Vision Institute of Canada. Her interest centers on community health optometry with an emphasis on the eye care needs of seniors. She provides mobile primary eye care services to several long-term care facilities into various multidisciplinary clinics, assisting underserved groups who face socioeconomic barriers to traditional care, such as the homeless and street-involved youth. She also provides low vision services at the Vision Institute Clinic, working with the growing population of those with partial sight. Her practice includes regular participation with volunteer eye care projects in the developing world. Dr. Tammy Labreche is a clinical associate professor at the School of Optometry and Vision Science. A graduate of the University of Waterloo, Dr. Labreche has earned a Bachelor of Science degree, a Doctor of Optometry degree, and a residency diploma in low vision and geriatrics. Dr. Labreche joined the faculty at the school in 2004 following several years in private practice and became a Fellow of the American Academy of Optometry in 2017. She provides patient care and student education, predominantly in the areas of external geriatric outreach and low vision in association with the University's Center for Sight Enhancement. She is the head of Rehabilitation Services and the director of the CSE. Her clinical expertise and scholarship interests address areas of low vision rehabilitation and geriatric vision outreach. Without further ado, please take it away, Drs. Lois Calder and Dr. Tammy Labreche, and I will be unmuting Lois now, as she will be our first presenter.
Hello, everybody, and welcome to our Part 3 of this exciting series. I encourage you to review Parts 1 and 2, given by our colleague Susan Leet, Dr. Susan Leet from the University of Waterloo. She gave a very thorough, clear description of aspects of vision to be considered in understanding the relationship between vision, aging, and falls. Her Part 1 provides a comprehensive review of the anatomy and physiology of the aging eye and how these relate to visual function. Vision, is far beyond the eye chart with the big E at the top, although we still rely on that, the measure of visual acuity. But it also involves other areas, nuances like contrast sensitivity, visual fields, color vision, glare sensitivity, dark and light adaptation, binocular vision, and so on. She does a good job of covering all that in part 1, because sometimes deficits in this system can be challenging for our older patients. And her part 2 discusses some nuances with respect to these vision changes as they relate to falls. She presented some really interesting research in this area. Today, Tammy and I are going to drill down into some more specific scenarios and hopefully contribute a little more to the story of these complex interrelationships. I'm going to talk first about double vision, followed by considerations in long-term care setting. Tammy will take over there to talk about vision and dementia and other systemic conditions that relate to vision loss. Let's start with this topic of double vision. It's fairly well established that disorders of binocular vision increase falls risk. There are sort of various forms of binocular vision disorders. We often think of them as loss of depth perception, or what we call stereo acuity. Some people face a monocular situation in which only one eye functions at all. Some folks have a lifelong situation of amblyopia, what some people call a lazy eye, in which one eye fails to ever develop good normal vision, stemming right back to childhood. But a very extreme and uncomfortable form of binocular vision disorder is double vision, and we sometimes call it diplopia. It's an extremely uncomfortable kind of situation.
Hi, Lois. This is Mariel. Can you just speak up a little bit?
Okay, I will try. How is that?
Thank you.
Is that any better? We'll carry on. Normal binocularity and depth perception comes about from the overlap of two slightly displaced image inputs from the eyes. That's because in the human face, the two eyes are separated a little bit, and each one sends its own information to the brain. And the brain puts the two images together into one single image. This slide depicts, on the left, normal binocularity. Everything's working together. Two eyes are working together. The middle slide depicts a little bit of horizontal double vision. And the third, a little bit of vertical double vision. In these particular images, the two images are not widely separated in visual space. Sometimes they are. Sometimes the two images are really far apart. In a case like this, where the double vision is a small amount, it's sometimes difficult for patients to describe it. It kind of resembles blurriness, and so it takes a little, drilling down to really get to the bottom of the story in some of these cases. Double vision can be congenital, and these patients usually develop coping strategies because the human brain and the visual system really hates double vision. It's really uncomfortable. So often in a case of someone born with poor binocular vision and potential double vision, the brain develops what we call suppression. That is, the brain just learns to naturally ignore one of the two images. That can be kind of a useful situation if it's necessary. And Sue, in one of her talks earlier, talked a little bit about other monocular cues that we use for assessing depth or a depth perception. Sometimes a person will develop a head tilt to just sort of, in their own way, get their two eyes to align. So sometimes we as practitioners, when we're trying to tease out the clues as to whether this is a new double vision problem or a long-standing one, we'll turn to the FAT scan, similar to the CAT scan, but in this case stands for Family Album Tomography, where we can literally look back at childhood photographs and see if there are signs of this double vision way back in childhood, like a head tilt. In any case, when it's acquired later in life, double vision can be very uncomfortable, disorienting, and dangerous from a fall standpoint. By definition, if you have double vision, you don't have good depth perception. There are a few common reasons for late onset double vision, and I'm just going to mention a few that I see on a pretty regular basis in my practice. Probably top of my list is the cranial nerve palsies. If you remember your anatomy and so on, the cranial nerves, there are 12 of them, are some of the major nerves that originate in the brain. And of the 12, 3 of them are directly responsible for eye movements. Damage to the cranial nerves is often associated with vasculopathic risk factors like diabetes, hypertension, heart disease, smoking, that kind of thing. There are other reasons for cranial nerve palsies, tumors, for example, or other diseases. But sometimes it's just idiopathic. We just don't know what's causing it, and it can resolve on its own, and that's the best case. Secondly, probably in my practice, most common reason would be some kind of other eye surgery, particularly retinal detachment surgery. Often in the repair of a retinal detachment, the surgeon has to put a buckle around the eyeball. Think literally of sort of like a big old elastic band put around the eyeball to get everything back in place. And that can interfere with the eye muscles, which are controlling binocular vision. Sometimes head injuries, concussions, and I'll put in that category also stroke sometimes can lead to double vision. And lastly, in my experience, another common reason would be what I'm calling a decompensating BV disorder. That is something that's always been there, but for some reason or other, the older patient is struggling to control it in their own natural, usual ways. Double vision may be constant or intermittent. It could be only in certain gaze directions. For example, the guy in the image there on the right, he apparently has a right sixth nerve palsy, which is giving him his right eye turning in toward his nose. But if he tilts his head in a certain way, he can manage that. The double vision may be only at distance or only at near, and so each case is a little bit different, and the way we deal with it may differ from person to person. It's pretty well established that binocular vision disorders in general are associated with a higher falls risk. This makes intuitive sense, as nearly all binocular vision disorders have a negative impact on depth perception. The study I mention here on this slide was a retrospective study exploring falls in a senior population, age 65 plus. The study compared those with a binocular vision disorder, and they had different categories there: strabismus, that's a turned eye without diplopia; diplopia or double vision; amblyopia that we mentioned earlier, and a few other things. And they matched those people with a group without any BV disorder, binocular vision disorder. And there were significantly more falls in the binocular vision disorder group, no surprise. But special mention was made that of all the types of binocular vision disorder, double vision had the strongest association with falls. So this study didn't establish direct cause and effect, but the association really provides, I think, a little more understanding. Now, another interesting study that jumped out at me was this one that described quality of life using a quality of life questionnaire with strabismic patients. Those are people with a turned eye, age 50 plus. Most of them did have double vision, versus patients with other ocular diseases. And you'll see here from the conclusion that the patients with binocular vision problems really reported significant impact on quality of life as much or worse than patients with diabetic retinopathy, age-related macular degeneration, glaucoma, cataract, and cytomegalovirus retinitis, which is a devastating viral retinal inflammation. And they also reported more pain on this quality of life survey. Those are devastating eye conditions, and so I was frankly surprised to hear that the patients with a BV problem really compared on that front. Okay, fortunately we have some options for relieving this kind of situation. I mentioned a few of them there. I won't spend any time on vision therapy today, the one at the bottom. There is definitely a role of programs of exercises to strengthen eye muscles and improve sensory integration of two images. Sometimes it's not our first line of attack in a case of an acute, organically caused extreme double vision. So I'm going to focus a little more today on Prism and surgery, which we do use on a regular basis. Prism is a kind of lens that does not focus light, but bends light so that it can move an images around in visual space, so that we can judiciously use it to move a patient's double images sort of closer together in visual space. And then they can sometimes manage to fuse the two into a single image better on their own. Sometimes we use Prism to fully compensate for the deviation of the two eyes, or at least partly. In any case, then the eye muscles are able to maybe do the rest of the work. They're called upon to do less work. You'll notice the prism on the left is pretty grotesque looking, pretty thick edges, and they do, in high powers, tend to have pretty thick edges, so we can't always build the prism into a spectacle lens. And then that brings us to the role of the Fresnel prism you'll see on the right. That is a plastic, flexible, thin, sort of striated version of the prism on the left. Not, extremely elegant, but you can apply these to a spectacle lens. You can trim them to fit, stick them on the back surface of the lens, and they're not terribly obvious. I will show you an example. Yes, this is Hillary. You may remember a few years ago she suffered some kind of head injury. I'm not sure what it was, but it temporarily affected her eye muscles, and she needed to wear a Fresnel prism for a while to relieve her double vision. Just from this image alone, a forensic optometrist, and yes, there is such a thing, could tell us a lot about Hillary's vision just from this photo. I understand probably her problem resolved on its own, and she's no longer wearing the Fresnel, so it can be temporary. Sometimes we use them permanently if we have to. Another strategy, I'd say more of a last resort, is occlusion. That is, if we cannot deal with the double image in any other way, we might just block one eye, and boom, you're back to one image. Not the most ideal, but sometimes necessary. We don't always use a good old-fashioned eye patch. Sometimes we can apply, and the little girl on the right is wearing a slightly occluding patch on her right eye. It's hard even to tell from the image. But if we can sometimes just blur an image a little bit, that can relieve the double vision, and we do use that strategy sometimes. Let's not discount the role of surgery in these kinds of cases. It's sometimes quite viable. You'd want a person to be stable and consistent before you'd tackle one of these cases surgically. But some of the studies show some pretty good outcomes. The one I quote here, for example, these were all seniors, age 65 plus. A majority of them had reported double vision. Not only did 63% report full resolution after their surgery, but an additional 23% reported some resolution. So partial correction can be valuable surgically, as this makes our optical options a little more feasible, and we can get away with less Prism, for example. Surgery is, I'm going to say, relatively low risk because you don't have to cut into an eyeball to realign muscles. So it's more of an external kind of surgery, which reduces risks for infection and that kind of thing. However, you need a good surgeon. There aren't a lot of surgeons who specialize in muscle surgery, but they're around, and it takes a fair bit of artistry to get a good outcome. So we do have some choices with double vision. It's awfully uncomfortable, but not hopeless. Now I'd like to switch topics to my second presentation, and as you see here, we're all interested in reducing fall risk in this vulnerable population. And we can do so, I think, if we can provide, as far as possible, clear, single, binocular vision in these patients. And if at the same time we can provide good quality of life visually, then we'll really have contributed something to the concept of well-being in this population. So what I want to do today is just provide and explore a few really practical tips and tricks for this kind of setting based on my practice. No surprise, I mean, there's a lot of overlap in this population, and all of these factors contribute to falls risk. I think the last stat I looked at suggested that long-term care residents in Ontario, I think about 15% had suffered a fall in the past year. You know, it varies from year to year, but that's the kind of numbers we're looking at, I would say. Eye care can be done on site in a long-term care setting. Tammy may discuss this a little bit later, especially as it relates to dementia. There aren't too many of us doing mobile care, but it can be done. A lot of studies do suggest there is a lack of care on site in long-term care. I'd like to encourage my students to consider that as a kind of a practice style. There's going to be a growing population, a growing need, and I think it's fun. So I try to encourage my students to consider that as a practice option. Today, in my long-term care half, I'm going to just mention a few things related to these particular aspects of vision care in long-term care. Let's start with spectacles. A lot of our residents are wearing spectacles, and we'll talk today a little bit about lens choices, frame choices, and care of spectacles. We could talk all day about lens choices. I'd like to distinguish here between residents who are ambulatory and those who are not. I have a feeling that falls from a wheelchair or from a seated position, in my view, don't have a lot to do with eyeglass design. And falls while transferring, say, from a bed to a wheelchair with, let's say, a one or two persons transfer. I don't think there's a big visual component to those kinds of falls. So here I'm talking more about falls from a standing position. I will mention a little bit of terminology. We sometimes talk about single vision glasses, which in that case they are just for distance or just for near, no bifocals. Then there are bifocals, which combine distance and near in one pair, and sometimes those are in the form of progressive lenses, where there's no line, but we still have all those components in the spectacle lens. And the term addition or add we use to describe the reading power required. There's a good review in part 2 by Sue about some of the studies involved with this. And often we do think, well, okay, let's give a person single vision distance glasses for navigating the ground. And that's a good option. It's safer, than, let's say, wearing a bifocal, because wearing a bifocal while walking means that the ground, by definition, is blurry, unless the wearer takes steps to avoid the reading section while looking at the ground. Easier said than done for some of our older folks. And it's true that for an ambulatory resident who's never worn bifocals, I would be very reluctant to prescribe a bifocal. But single vision distance is kind of inconvenient, because as long as you're wearing those glasses, you don't have very good near vision. And in fact, in some of these studies, people sort of discontinued their single vision distance walking glasses because it was so inconvenient. So a very interesting study emerged that, well, what if we don't prescribe the full reading bifocal, but really cut it back to more of an intermediate reading lens? And in this particular study, the researchers reduced the reading power by 1.5 diopters from whatever the person was wearing habitually. So what we're looking at here is, less than half of their usual reading power. And interestingly, this did seem to reduce falls risk compared with a full edition lens, and allowed for some sort of acceptable reading vision at the same time. So the person didn't have to switch glasses constantly all day long while they're switching visual tasks. I would also mention at this point that multiple pair of glasses are a bit of an economic burden on people. I have often a conversation with a family member. Mom doesn't read anymore, so she doesn't need bifocals. Well, bifocals aren't just for reading. We use them unconsciously a lot during a day, to see the food on your plate, to look at a family photo, to read a birthday card, to look at your watch for the time. Bifocals are still a great option for those who can wear them safely, and I would not lightly take away a bifocal from someone who can manage the risk. And I do try to explain that to families. Bottom line, kind of a case-by-case basis when it comes to lens choice. Frame choice. I would say familiar is usually best. You don't want to radically change somebody's style or size of frame all at once. In our older folks, the skin on the nose area, on the bridge, is really, really thin and vulnerable to breakdown. So when possible, I might like to avoid nose pads in favor of a one-piece bridge that spreads the weight out a little bit better. And we try not to have the temple, that's the part that goes over your ears, not too wide to block peripheral vision. That story makes me think of Eleanor. I first encountered her at a long-term care place, first admission, eye exam. She was pretty bitter, and she had this old frame, the one on the top. We can pretty much date that frame to circa 1970s. It was very brittle. Every time I saw her, I had to do some kind of an adjustment on it or a little repair, and I was really nervous about this frame. But she was adamant she did not want a new frame. So finally, they broke irreparably. Meanwhile, I kept the frame you see on the bottom there in my kit for years, like probably a decade or more. It's kind of homely, but I had a hunch that I'd find a home for it. And sure enough, she allowed me to put her lenses, cut them down into that new old frame, and she's managing it quite well. In fact, she's using the glasses a lot for bingo and needlework, and she wins a lot at bingo. I'm not sure if I can credit her new old eyeglasses with that, but she's a happier person, and I hope I contributed to that a little bit. Spectacle care is a day-to-day issue in a nursing home. Probably my most frequently asked question of all times in my whole career has been, how do I clean my glasses? Nothing special. Just avoid harsh cleaning agents like alcohol or Windex. Try to use just regular soap, and dish soap is good. The soap you have in the dispensers in long-term care is good enough. And try to dry the lenses with fairly soft, not those harsh paper towels we sometimes have in nursing home bathrooms. Lens coatings can go awry, as you see here, just through time and wear and tear and heat and harsh cleaning. A very observant nurse that I work with at one of my places noticed this resident's glasses, and you can even see through that lens. It causes sort of a functional loss. The field on the left there is kind of blurry through that bad coating, so sometimes we have to replace lenses. Here's something that comes up often, and that is lost lenses. Here's a typical bedside top drawer. There's a lens in there, pretty much invisible, and a busy PSW could easily miss finding a lens in the back of the drawer, but it's there, and sometimes we can just get away with finding it and replacing it without too much to do. Repairs. This lady who belonged to these glasses found the glasses in this position, and so the staff put them away, waiting for me to come and fix them. And it was a couple of weeks before I could get there, and really it was a very, very simple fix, just a screwdriver and a pair of pliers, and it was done. And so I'd like to consider the possibility that we could enlist volunteers or family members to do these kinds of repairs without waiting for, an eye exam somewhere. Very simple. Perhaps you could establish a connection with a local optician who'd probably be happy to do little repairs, especially if a volunteer can get the damaged eyewear out without too much trouble. Could I give you some practical tips for communication in a long-term care setting involving the residents, the staff, the family, and eye care providers? Keep everybody on the same page. This is my mother-in-law. Thanks, Pauline. She actually lives in long-term care, and I often come across photos in electronic medical records and elsewhere that are really just bad photos, blurry, no glasses. It's better if we can have some identifiable photos of the eyewear and, if possible, the person wearing the eyewear. It gives us lots of clues as to whose glasses are whose. Here's a great idea. And I got to give a shout out to Adrian, who heads up the restorative care team at one of my homes. He came up with this idea of having a binder in his office documenting people's eyewear. Here's a sample from inside his binder. I've removed the identity of the residents. These are reasonably good photos. You can see bifocals, or sometimes in some cases. It's a really great resource. It does need dedicated updating, and so it works best perhaps in a smaller facility. This particular place has about 100 beds, and it's only as useful as its most recent update, but I think it's a great idea, and I use it when I'm at that home sometimes. Anything that's going on, great to keep everybody informed. On shift changes, for example, if somebody has new glasses, let's let everybody know and kind of alert people so they'll have a heads up. Or if something develops like a broken pair, great to chart that in progress notes. For example, residents' broken eyeglasses are locked in the med cart or something like that. It keeps everybody on the same page and keeps people from hunting needlessly. Falls signage. Here's a really great falls prevention poster that's beside a bed, but there's nothing on there about eyewear, and I think it would be fairly easy to add a little icon and checkbox about whether the person should be wearing their glasses or not. Surgery. There's lots of information about how cataract surgery, for example, reduces falls risk. There's a little controversy over doing one eye or two eyes, but that's sort of resolving. One little wrinkle on this is what we call monovision. That's where we deliberately correct one eye for distance and one eye for near. Sometimes we do it with contact lenses, and sometimes surgically. A cataract surgeon can choose to do this. It kind of works. It's a bit of a compromise, but it's becoming, I think, more popular, especially in the boomer generation who are now developing cataracts. And I have a hunch that maybe our future long-term care population may be living with monovision, which does reduce depth perception and increases fall risk. Wait times can be a bit of an issue depending on your community. There is a site there where you can check wait times from hospital to hospital and maybe get things sort of coordinated a little more expeditiously sometimes by choosing a different surgeon. There's also poor uptake on surgery in nursing homes for lots of obvious reasons, comorbidities, logistics of transporting people, scheduling, and a lack of an advocate. One of the studies I mentioned here on this slide compared people with an advocate and those without, and there was a shocking lack of uptake in cataract surgery in the group of patients who'd had no help to get out to a cataract surgery appointment. We have to be careful about eyewear following cataracts. Big changes, sudden changes in eyeglass prescription can be a bit of a falls risk, so case by case. I wouldn't say that advanced disease is a barrier necessarily. I have a patient named Bert who has, as it happens, terminal metastatic prostate cancer. But he had a cataract that was really interfering with his quality of life. He's a big reader. And we found a surgeon who was willing to take him on, and he's had that cataract removed and is really enjoying his restored vision, despite his other devastating situations. I won't spend too much time on environment, but lots of studies suggest that lighting is pretty poor in long-term care facilities, beyond the scope of my expertise here. I think possibly the newer homes that I visit are improving on this front. And I'll just quickly mention training, that balance is a big part of falls reduction, and that some studies involving people with low vision suggest that training for balance, like Tai Chi, for example, can contribute to reduction in falls. So in summary, I think our goal is to provide the conditions in long-term care to allow two eyes, each to be as clear as possible, to work together, and that's our goal in reducing falls risk, and at the same time providing good visual comfort. So for me, that's the bottom line, quality of life. Let's work on that. And I'm going to turn things over to Tammy.
Hi, everybody. Please let me know if you can't hear me. Thank you for joining in this afternoon over your lunch period. And I will try to go through the remainder of the slides so that you can get back to the rest of your day. Thanks, Lois. That was wonderful. I wanted to start out by delving a little bit more into vision and dementia. For those of you that do work with individuals that do have dementia, you're aware that that in it itself is a falls risk. But what you may not have known is that with some different types of dementia, there may also be different visual impairments that crop up. So that's what we're about to go over this afternoon. And just to make sure everybody is on the same page, when I'm talking about dementia, I am talking about the disease process, not the normal aging, occasional memory loss, but the actual disease process that causes the deterioration in cognitive ability. To have somebody declared as having dementia, there must be significant decline in two of the following functions: memory, reasoning and judgment, communication, attention focus, and the last one I've highlighted here because we are doing vision and dementia is visual perception. As you're aware, there's not really good definitive ways of diagnosing the different types of dementia. A lot of the times it's done more on symptoms until postmortem. So we're going to describe the different types of dementia and how they relate to decreases in visual function. So here are the few different types of dementia that I'll speak about this afternoon. Alzheimer's. Alzheimer's is a form of dementia, dementia being the umbrella term, but it is the biggest or the most prevalent form of dementia in our older population. Vascular dementia, dementia with Lewy bodies, mixed dementia, Parkinson's disease, and frontotemporal dementia. I'll speak briefly about all these different types of dementia aside from the mixed dementia. And just keep in mind this is not an exhaustive list. So there are other forms of dementia that are not mentioned here. So we'll start with Alzheimer's. As I had indicated, it is the most common type of dementia. It affects about 60 to 80% of those that do have dementia. It does typically affect those that are 65 plus. Unfortunately, I've had the unfortunate opportunity to meet somebody that had fairly advanced Alzheimer in her late 40s, so it can occur earlier on in life as well. Post-mortem, they find these tangles and plaques that are deposited in the brain. When we think of Alzheimer's, we don't necessarily think of impact on visual function, but there have been different studies out there that have indicated that in the later stages, there could be an associated visual acuity loss. And there's also possibly a decrease in stereo acuity as well as contrast sensitivity. And I'll explain those two a little bit later on. Underneath the Alzheimer's umbrella is something called posterior cortical atrophy. This is also dubbed visual dementia. It is thought to be caused by Alzheimer's, but the degeneration occurs at the back of the brain, not the eye, but at the back of the brain. So the initial symptoms are changes in vision. And in fact, memory and the other impacts of the dementia are often preserved in this type of dementia. With posterior cortical atrophy, there can be eye movement abnormalities, difficulty with visual crowding, and a diminished useful field of view. So that's your side vision, and it's not the full extent of your peripheral vision that I'm talking about here. It's the extent of your peripheral vision that you're attending to at any given time. So even though we may be able to say way out at 80 degrees in our peripheral vision, we may not be really attending to that part. We find that this does decrease over age, but in those with posterior cortical atrophy, this diminishes to a further degree. Vascular dementia following stroke, typically. It is the second most common cause of dementia. Memory loss is not the first symptom. Typically, there's more problems with judging and planning. However, there may also be some impact on visual function. There is, similar to Alzheimer's, some studies that point to potential decrease in stereo acuity. Again, as Lois had mentioned, that's kind of the demonstration of how well our eyes are working together, how well we can see things in depth perception, as well as a decrease in that contrast sensitivity. And maybe I'll describe what contrast sensitivity is right here. So for those of you that are not familiar with the term, contrast sensitivity is our ability to see a more faded target. So our acuity charts actually start out nice and dark, and they go into more faded or lighter gray shades. We have our traditional visual acuity chart, but for those of you that have had eye exams, which I'm hoping it's all of you, you know that the very first test we do is the visual acuity test, which is a beautiful black on a beautiful white. This is useful for many, many different things. However, to really have a good understanding of how a patient is functioning in life and not just how their eye is functioning, contrast sensitivity is a really good cue. Our world is not black and white, right? That would be very boring. Our world is shades of gray. In terms of vascular dementia, particularly because it's most often following a stroke, we also know that following a stroke, at least about 25% of those have also some form of a residual vision loss from the stroke. I will go over these in just a few slides as well when I talk about more of the systemic conditions that impact falls. These include visual field loss, so more impact on that peripheral vision, eye movement disorders, reduced visual acuity, and diminished visual perception. Dementia with Lewy bodies, it's deposits of the alpha-synuclein protein that develop in the cortex. Typically, there is early memory loss, but also early sleep disturbances. In this form of dementia, there is the possibility of visual hallucinations as well as muscle rigidity. So in addition to those visual hallucinations, they also have more difficulty with perceiving. Okay, so visual perception, discrimination, difficulty with space and motion and object form perception. I want to go back just a few minutes and discuss visual hallucinations, because visual hallucinations can occur also with individuals that just have poor vision. All right, so how do we tell the difference between somebody that's having a visual hallucination due to a cognitive impairment or somebody that's having a visual hallucination that's simply as a result of a reduction in vision? So when we do have a visual hallucination that's as a result of a reduction in vision, this is dubbed Charles-Bonnet syndrome. It's kind of like a phantom limb syndrome. So we do have some random firings. The patient is trying to put together that image into something that is familiar to them. The difference between this and something that is a visual hallucination as a result of a cognitive decline is that the images are not scary. The patient is not afraid of what they are seeing, and second, they know that that image is not real. So for example, I had a patient that had a low vision assessment here at the university. She had advanced macular degeneration, as well as some other systemic conditions, dementia being one of them, Alzheimer's in particular. She left the clinic and she called back and said, "Can you touch base with your students, because I think they might have lost a pet lizard. I had a pet lizard crawl up my leg while I was in the car on the way home." So the question I have is this Charles-Bonnet syndrome because of her advanced macular degeneration, or is this a visual hallucination because of the dementia? And it's actually a visual hallucination as a result of the dementia. She thought that the image was real, so she was thinking that there really was a lizard in her car, and in fact, she felt the lizard crawl up her leg. Okay, so for Charles-Bonnet, not scary, not intimidating. They know it's not real. They're usually a little embarrassed to talk about it, and they can differentiate between the fact that it was real and not real. Parkinson's disease, the dementia in Parkinson's disease is similar to that of Lewy body dementia, and it does progress. The dementia portion of Parkinson's disease is typically towards the end stage of the disease process. Again, remember that the movement disorder is the initial symptom, and the visual changes that do occur with Parkinson's disease are very similar to Lewy body dementia. So you have those visual hallucination as well as those eye movement concerns and the difficulties with perception. Frontotemporal dementia, usually a little bit younger onset, a little scary, but usually a little younger onset. And as the name implies, it's a degeneration that occurs in the frontal and temporal lobes. So you have difficulties in planning and judgment, emotions, speaking and understanding speech, and some movement difficulties. There is three broad categories of frontotemporal dementia. behavioral variant FTD, primary progressive aphasia, and FTD movement disorders. And under this last category, I do want to bring to your attention something called progressive supranuclear palsy. For those of you that do work in a long-term care facility, you will have come across individuals with all these different types of dementia, but even something called progressive supranuclear palsy, which is even more rare than some of the other conditions. With progressive supranuclear palsy, the hallmark sign is actually a reduction in eye movement. So the definitive symptom is that the patient is not able to move their eyes vertically. So this is just a little chart that I've adapted from an article that Armstrong and Kurgoat I know is out of Montreal, has put together. They have done a really good review on all of the different studies of dementia and vision. And so it's just a little review of what we just went through. This is the ultimate question. Does reduced vision cause or further progress dementia? And the final verdict is really not out. So I do have a study here that's included which points to the possibility that a reduction in vision does cause further progression of dementia. But then you will also find the studies that point to it just being kind of coexisting. So the final verdict is not out. However, we do know that reduced vision will exacerbate the symptoms of dementia. So if you have an individual that has dementia and they're moving different homes, let's say from their own home to a long-term care facility, there is going to be an element of confusion initially due to the dementia, but if you also throw in vision loss on top of that, that will make it more compounded. So you might think, okay, you have a patient with dementia. You have these eye changes that can occur that you want to address to hopefully minimize the falls risk. How do we go about conducting an eye exam for a person with dementia? We need to get all the information that we possibly can. We can never assume that a patient with dementia will not be able to fully participate in the eye exam. As Lois does right now, I have in the past, and actually just the very recent past, spent a lot of my time in long-term care facilities, and it really depends. Right? You may be able to do a complete eye exam. Maybe just some of the questions, some of the dates might be a little fuzzy, but to be honest, sometimes the dates for me are a little fuzzy for, different surgeries. Or you might just be doing an eye exam with somebody that's completely nonverbal. First of all, we do need to adjust our communication strategies. If we're in an office or even in a long-term care facility, we try to reduce the extra noise in the room. We know that we might need an extra little bit of time just to do some extra different types of testing, but we never exclude the patient from the conversation. We don't try to impose that power stance of standing too close or above the individual because that can be very intimidating. We try to speak clearly and at a slower pace and present one idea at a time or present just simple yes-no questions that have limited options for decision making. When interacting with an individual that does have dementia, we may find that we have to repeat ourselves many times. I don't know how many times a day, and Lois, you'll be able to speak to this yourself, that I reintroduce myself to that same person. Okay, so I'll say, hi, how are you? I'm Dr. Labreche. I'll be doing your eye exam today. And then I'll go across the room, and I come back, and I'll be like, oh, who are you? And you just keep going with it. Go with the flow. Hi, my name is Dr. Labreche. I'll be doing your eye exam today, and we continue on. Patients are never contradicted, so that if there is some questionable responses, we go with the flow again. If they're concerned that somebody is stealing their purse, we tell them that we will send somebody to check on it instead of denying it. We do have objective tests that we can do, so we do not have to rely completely on the patient's subjective responses. If testing is not successful, we do make an attempt on another day. I had this lady that I had seen in a long-term care facility who, in addition to having dementia, spoke only German. So the only way they were able to bring this lady down for her eye exam was to tell her that she was going for a cigarette. Let me tell you, when she got down to see me, and it was me and not a cigarette, she was not happy. She was not having any of that eye exam. We could not do much testing. So we abandoned it, and we brought her in on another day where we had her daughter speak to her in her native language and explain to her what we were doing. She was able to do everything. So that communication piece is really key, and remembering that what we do on one day may not be the same as what we have on another day. So when we're considering risk for falls, patient with dementia, patient otherwise, we're looking for a reduction in visual acuity, that contrast sensitivity, the depth perception, field loss, inappropriate spectacle correction, difficulties with light adaptation, and glare sensitivity. We will still provide an updated prescription for those individuals with dementia, but as Lois had mentioned, maybe we will avoid prescribing new bifocals. If somebody has a progressive supranuclear palsy form of dementia, we know that they're not able to move their eyes up and down. We will definitely take them out of their bifocals. We will watch the frames, and we will potentially prescribe different types of filters for light adaptation and glare sensitivity. We will still refer for cataract surgery. That lady that spoke German, she had a dense cataract in one eye. We referred her for cataract surgery. It was successful, and she was tickled. So it is possible. Keep in mind for those individuals with dementia, typically cataract surgery is done with just more of a local anesthetic. With those with dementia, they may have to have a general anesthetic, which may have some side effects that are unwanted for our older population. We will manage the contrast sensitivity loss. We will consider different filters. We will discuss using high contrast borders. We will discuss good lighting. In terms of management of any field loss, we will cancel patients and their loved ones and care providers on the importance of uncluttered and consistent habitual environments, and potentially referral for orientation mobility training if we feel that the patient may be able to have that type of training. So for the last few minutes, I'm just going to talk about the impact of systemic conditions on visual function. So we know about the visual conditions, macular degeneration, glaucoma, and so on, that impact visual function and can be a visual risk factor for falls. Just a reminder that we do have different systemic conditions that can result in a loss of visual function as well. And I am going to start with diabetic retinopathy as a result of systemic diabetes. Typically, it is as a result of systemic diabetes that is not well controlled, but in the group of individuals that have an insulin-dependent diabetes, sometimes it can occur even with those that have well-controlled diabetes. It can be associated, in addition to the visual impairment of the diabetic retinopathy, it can also be associated with glaucoma and premature cataracts. And just a little diagram here of what we're seeing at the back of the eye and what that patient might be seeing with diabetic retinopathy. So there will be a decrease in overall visual acuity, a decrease in contrast sensitivity, fluctuating refractive error, potential loss of vision in one eye, potentially experience double vision. And as we know, these are all risk factors for falls. Hypertensive retinopathy, the visual changes from hypertension are usually end stage. Okay. It can also it could also create a situation of double vision. The one thing I do want to note, though, is that if somebody has hypertension, it can lead to other conditions like a retinal artery or vein occlusion, where you'll be left in a situation where the vision in one eye is significantly reduced permanently. you're putting to a monocular situation, vision good only in one eye, your depth perception is going to be significantly impacted, and your visual field will be mildly reduced. Arteritic anterior ischemic optic neuropathy as a result of giant cell arteritis. So this is our big scary dude that we are always afraid of in those individuals that are over 65. If it's not caught quickly enough, it can cause permanent and irreversible vision loss. It starts initially with a reduction in visual field. So the visual field loss will be initially one of the initial visual symptoms, but it can progress into full loss of vision. Stroke is another one I did want to highlight. So in addition to all of the other impairments that happen as a result of stroke, there are those visual sequelae, alignment and movement impairments. At the top of the list, visual field impairment, our hemiopic losses, low vision, and perceptual impairments. And with stroke, when I'm talking about perceptual impairments, I'm just going to skip over these last couple of slides here, the visual pathways, but they're there for you to peruse. We're talking about neglect, extinction, and visual midline shift syndrome. So neglect, it's a higher order visual processing skill. It's that lack of awareness of one side of visual space. And as those of you that work with individuals in neuro rehab units, individuals with stroke, this lack of awareness can happen in several different spaces: personal, peripersonal, extrapersonal space. We have another form of neglect. We're not exactly sure if it's resolving neglect, but with something called extinction, when somebody is presented with images on both sides of their vision, they'll attend to the one side only. If it's only presented one side or the other, they can see it fine. And finally, midline shift. So if we have loss on one side of our vision, one side of our body, is potential for our midline to shift as well, which could potentially lead in itself to falls. All right, I apologize for really speeding up towards the end, but thank you so much for spending your lunchtime with us. Do you have any questions?
Perfect. Thank you so much, Tammy and Lois. And Lois, I have unmuted you for now briefly in case you would like to chime in on anything. Okay. We are running, I can recognize that we are running a little bit over time, but we can, the webinar platform is okay to run a little bit over time. If anybody has any questions, I have been encouraging people to type their questions into the chat box, and if we're not able to get to them immediately, we can definitely connect with our presenters and have them respond to you via email or on loop. I do have just a comment from Rosalie saying that I've had temporary double vision from a corneal scratch. This occurred from a dry eye situation, which isn't uncommon as we age.
Yes, I think that's a good point. There is such a thing as monocular double vision, where the double vision comes from a sort of a distorted image, which you probably had through your damaged cornea. And that's another category as well of double vision. Indeed. I hope it's better.
Wonderful. Thank you so much. So again, just to reiterate, if anybody has any questions, feel free to type them into the chat box. I will take the time right now to do my little shameless plug. It is November, which means it is Fall Prevention Month, and this is our third webinar in our series in November of webinars for Fall Prevention Month. You can visit our website to see what other people are doing for Fall Prevention Month, as well as access our toolkit. For upcoming webinars, we have just released the invitation for our next webinar, which is happening in February 19. My mind isn't ready for 2019 yet, apparently. And it will be with Pam Howell from Briere, looking at deprescribing and preventing falls. And this slide is just about our fall prevention community of practice, so you can please visit us at onloop at fallsloop.com. And this year, we've actually launched a new online community of practice for children's fall prevention called Loop Junior. If you have a passion and interest in children's fall prevention, please join us, and the website will be on your screen right now. And I would like to once again thank Tammy and Lois for a wonderful presentation and all of your practical tips, especially as they pertain to long-term care. If there are any other questions from our participants, I will be forwarding them over to you. Please do not close this window just yet. Wait until you have been redirected to the next screen where a brief evaluation survey will launch in your browser. We always appreciate if you could provide feedback so that we can continue to offer high-quality webinars. Thank you so much and have a wonderful day. See you next time.